Hello everybody, it's Kat here, the Vet Talent Manager, and I'd just like to welcome you all to this short webinar series that we are running as part of our practical dentistry course for everybody on the graduate programme this year. This is an essential part of the dentistry CPD, and by pre-recording the main lecture topics with the main kind of course tutor presenter Alex Smithson, it means that we're going to be able to give you as much practical time as we can on the actual days themselves. So I would really just sort of emphasise to you all that these are an essential pre-watch for the days. You'll need to watch these to participate completely in the day and to understand a lot of what is being taught. Alex is going to assume that these have been watched. There will be opportunities to ask questions on the content of the day, so when you're watching them, please save up your questions and take them along for Alex on the day. And without further ado, I'd like to hand over to Alex for the first webinar, which is focused on dental and oral investigation. So over to you, Alex.
Thank you very much, Kat. Right, so we'll start off and try and get a bit of a good understanding of how to approach your cases, and then hopefully this will all go in with the practical elements and make things a lot clearer for you, and hopefully give you a good grounding and confidence in meeting oral and dental cases. Just as a bit of background, you'll see there's the human and the veterinary side. So occasionally I will mention things about human dentistry, but only where it's relevant, of course. But sometimes it's quite handy to use that yourselves, because when you parallel with the human situation, a lot of the time actually that's when your clients will start to understand things. It's what they've perhaps experienced at their dentist, or if not themselves personally, then often a friend or a family member, and it will start to sort of ring bells in their mind and help you to help their pets. So we've got a few aims and objectives as ever. Want to have a quick look at normal anatomy, and hopefully this will be a bit of a refresher, but I know that there's quite a variable level of dentistry taught in the vet schools, so hopefully this will bring you up to speed. And just to make you aware of what happens as our animals start to age, think about how we would go about investigating our cases and how that differs between both conscious and also, of course, unconscious examination. And the latter will include, of course, probing and charting. That's the mainstay, really, of our first parts of investigation. Know what we're doing in terms of when we're charting, how we score things, and add investigations in an appropriate way. Of course, a lot of that is going to be down to X-ray, which is another topic, but we're going to start to whet your appetite about that and hopefully guide you down the right way. So, first off then, canine dental formula. So, of course, in both the cat and the dog, as well as other species, the shape and the form of the teeth is very much geared to function. So we're getting similar teeth, of course, in both cat and dog, but there are slight differences, and it's useful to know how many teeth we start off with. So of course in the dog it will be 42, and in the cat it will be 30. It does vary a little. There's individual variations, extra teeth, missing teeth, etc., and we'll look at that a little later on. But basically, if we know that, then if we're taking teeth out and an owner says, oh, how many teeth have they got left, or how many did they start with, etc., then we can have a bit more confidence in answering the questions. The cat, of course, does have the same type of teeth in size as canines, premolars and molars, but it's refined down relative to the dog, and that's all part and parcel of it being an obligate carnivore. So we have fewer premolars and fewer molars. The canines and the incisors, of course, remain the same. So we've got our incisors, which are the nibbling, grooming teeth, the canines then catching, holding teeth. Premolars, you can see how they create a sort of a scissor type effect, like pinking shears, so they're for cutting up food. And then molars, as we get to the flattened surface molars that are rather like our own, then they are for crushing and grinding. And of course in the cat that's very minimal, whereas in the dog there are a number of these molar teeth. You'll also see that in terms of at what point we're getting our deciduous teeth replaced by the permanent teeth, so succession, it's at around the same age in both cats and dogs. So between about the ages of typically 3 to 6 months. Now there is variation again, so individually, but also with breeds, and a lot of these little mini breeds that we get now, often it's quite a lot more delayed than that. So our normal anatomy then, if we think first of our crown, then you'll see and probably already know that the outer surface in cats, dogs, ourselves is enamel. The difference really between ourselves and our patients is that our enamel is a lot thicker. So unfortunately, cats and dogs is extremely thin, and this makes it rather easy for a fracture to remove the full thickness. And because the enamel, it's like glass, and it's this outer surface that's very, very dense, the densest substance in the body, and also kind of the bug-proof surface layer, if you will. But the fact that it's like glass, it's relatively fragile. So unfortunately, once it's formed, we don't get reformation. And so if we lose it, then we're down onto our next substance, which is the dentine. So the dentine, and I'll take the pointer here so we can hopefully do this more clearly. Okay, so our enamel, that thin outer surface of the crown. Underneath we have the dentine, and you can see that this makes up the bulk of the tooth in our mature animal, at least. And the dentine, as you'll see there, it is a dense substance, the second most dense substance, but it is also porous, so we'll look at that a little later. Centrally, our pulp. Well, we know that there's nervous tissue in there, but there's more to it than just that, of course, but certainly it is extremely sensitive to anything and registers this primarily as pain. And then on the outside of the tooth, we have our cementum, and that's coating our root, of course, very thin layer generally. And then we've got our PDL, our periodontal ligament fibers, and they're just suspending our tooth there in the socket, and they run between the socket or alveolar bone and the cementum of the root. So our socket bone, our alveolar bone there, and of course the gingiva is here with this margin at this point. Same on the other side, that margin, that free margin of the gum, so this keratinized tissue, and the sulcus between, so that little sort of natural gap that runs away around every tooth. And we usually have this point at which we can fairly clearly see the enamel meet the cementum. So the smooth enamel meets the rough cementum at the CEJ, the cemento-enamel junction. And it's at that point we generally regard our tissues to attach. Of course, when we've got this gap, the sulcus, or if we're starting to get disease, then we can measure this gap, and that's our probing depth. So a periodontal probing depth, and that might be normal. It might just be a sulcal depth. So in dogs, typically about 3 millimeters on most teeth. In cats, 0 to half a millimeter on most teeth. On the canines, it tends to be a little deeper, maybe up to about 1 millimeter on a cat, and up to about 5 millimeters in a dog. So that's periodontal probing depth. It doesn't necessarily mean that we've got disease. It depends on, of course, what we measure. So the pulp dentine organ is referring to the fact that the pulp is laying down the dentine, it's producing the dentine. And of course the tooth size remains the same, so as our animal matures, and that includes ourselves, then the pulp becomes restricted to a narrower and narrower space as the walls of the dentine become thicker and thicker. In addition to thickening the walls, the other thing is that in a very young animal, then the apex, the tip of the root, is not formed. We've got very thin walls and they just stop, and then the pulp is basically continuous into the bony area. But as the animal matures and reaches about a year in age, we start to see the apex close off here. And we tend to regard the apex as fully formed at about 80 months of age. And at that point we have our apical delta. Now, what that's referring to is that if we were to take a scanning electron microscope and have a little look, then we would see that instead of being completely blocked off, of course, there's got to be some means for blood vessels, nerves, etc. to enter and leave our pulp. And so actually this resembles microscopically a little sieve, and there's these tiny channels through which our blood vessels, nerves, also lymph, etc. can go through. So we have our pulp dentine organ central to the tooth, and then on the outside we have our periodontium, which we'll talk about a little further. Just go back to our pulp dentine organ and looking at how the dentine is formed and what goes on with the dentine, then you'll see in this radiograph of a young puppy how we've got a whole series here of deciduous teeth, and that they're sitting here right above the developing permanent tooth buds, and how there's very little bone actually, but in fact there's really very little hard tissue at all. So if we have a little look at that bud, for example, of a canine, then really a lot of it is quite lucent because most of it is basically made up of pulp, and it's a very, very thin shell there of our dentine and then enamel. Take a mature animal's tooth, extract it, take a cross section, and then look down on top, and this is very stylized image of course. Then what you'll see is centrally we have our pulp, and then running through the dentine are all these tubules, and they radiate out from the pulp to the outermost aspect of the dentine. It's like spokes of a wheel, and within there we have effectively nerve endings. In other words, there is sensation from the pulp throughout the dentine right to its outermost aspect. So it's useful to remember both from a sensation point of view, but also to think of those little tubules as potentially a means of ingress of bacteria. And here we can see we're maturing now, and we've got the deciduous tooth with the thicker dentine. However, our immature permanent tooth here, this canine, you can see that the walls are extremely thin, and they just kind of stop. That one stopped there, and again here come to an abrupt halt, and all of this is our pulp, and it just seems to continue into the bone there. And of course that's because this is a young animal, so we're looking here probably about 5 months of age, something like that. And then fully mature, and you can see how the apex, that root tip, is now closed off, and we've got thick walls, narrow pulp, and in that apex of course we'll have our apical delta. Now if we looked at the outside of the dentine here, and it could be either below the enamel in the crown, or it could be below the cementum in the root. Once we've removed that outer layer, if we were to then use, again, scanning electron microscope, this is what we would see. These tiny little holes that are leading to each of those tubules, and of course depending on their width, a lot of the time, especially in a less mature animal, then they're amply wide enough for a bacterium to gain entry. So the periodontium, we refer to the 4 tissues, the 4 periodontal tissues collectively as the periodontium, and they together form a very important part of the tooth because they're what attaches it basically, and also what forms the seal, the protective seal between the oral cavity, which is absolutely full of bacteria, so basically this little cesspit of the mouth, and then protection between that and of course the blood vessels, etc. And this is what creates that seal. It's as good as the body can do. It's not perfect, unfortunately. Also, it's not brilliant at reformation once it's been damaged, regeneration. So of course we've got our alveolar bone, the periodontal ligament fibers suspending the tooth within the socket, and it's those that we've got to break down when we extract, and the alveolar bone and the socket that we've got to very, very slightly expand in order to enable this tooth to loosen and be removed. The cementum Thin layer, as we've said, it's cement-like, so it's a rough coating to the outside of the root. And then the final of the 4 is our gingiva, heavily keratinized, specialized oral mucosa. And you'll notice again that we have our sulcus just here. And this is extremely important. It's our epithelial attachment. And you can see how it's focused around the cemento enamel junction. But that is what we're always trying to protect. Okay, well, we will look at that in a bit more detail, but we'll come on to nomenclature now. So, of course, the face can be divided into 4 quadrants: right, left, upper and lower. And we then use our numbering system to identify teeth within that. So I'm sure you've all seen things like 204, etc. So 3 digits. The first number refers to the quadrant, and right upper starts with a 1, left upper with a 2, and then you drop straight down to the left lower, that starts with a 3, and across to the right lower, that starts with a 4. So we identify the quadrant with the first number, and our second 2 digits are what tell us exactly which specific tooth we're looking at. So again, fairly simply, it starts at the most central incisor, assuming it's there. It would always start there, whether it's missing or whether you've got extras. So if it's missing, then when we start to use charts, we just say that that particular tooth is missing. If we had extra teeth, supernumerary teeth, we would try, it's not always easy, but we would try and work out which one was the supernumerary and which we thought was the normal one, if you will. And it doesn't matter massively at the end of the day if you find that tricky in some cases, but we would denote one of them at least as the same number but supernumerary. So if we had 2 204s, we'd have 204 and 204 SN supernumerary. It wouldn't alter the numbering system. Now, in addition to these numbers to identify things, we also use some slightly different labels in the mouth relative to the rest of the body. So the first thing to think about is mesial and distal, and what we refer to with those is relative proximity to this rostral midline. So of course the midline is going to head in a caudal direction, but we're only bothered about this very most rostral element of it, and mesial is the aspect of a tooth closest to that rostral midline. So of course if we took this tooth, which is upper right as the first incisor, so it would be 101, here would be the mesial aspect of that tooth. The furthest away from that rostral midline is referred to as distal. So again, here will be the most distal aspect of 101. And as we head around this arcade, that remains the same. So for example, here this will be the mesial aspect of that canine, that's 104, and distal would be here. Ditto, here we would have mesial, distal, because it's all referring to that rostral element of midline. Labial, we're talking about canines and incisors, their outer aspect, what you might want to call rostral, and these teeth are in the smile line, so next to the lips, so their outer surface is next to the labial surface, so that is the labial surface of those teeth. Okay. Whereas if we were looking at, again, you might want to call it the lateral aspect, so we're talking now about premolars and molars. Well, they're next to the cheeks. The cheeks contain the buccinator muscles, so this is the buccal surface of these teeth. Once we go inside the mouth, then we, on the lower jaw, will be next to the tongue, the linguum. So the inside, you might want to call it medial perhaps, but it's not. It's next to the tongue, so we call that the lingual aspect of those teeth. Whereas in the upper jaw, of course, we're next to the palate, so it's the palatal surface. The final surface, the occlusal surface, is the biting surface. So again, we have these occlusal surfaces here, the bits that bite together. So oral investigation there, we need to look at all of these things, and we can do a certain amount of that conscious, but really we're going to rely on our general anaesthetic. So from a conscious point of view, the first thing is to ensure that we are fully happy that this is looking at part of an animal, but we need to look in a holistic way. So we need to get a full history, full conscious exam. We don't just suddenly zoom in and look at mouths and teeth. So try and get everything that might be relevant, and that could be anything really. And of course, some of it might be totally separate to the mouth, but it could be very relevant to safety of anaesthetic, for example. So what's the heart like, what's the pulse feel like, etc. So the usual approach where we do full history, full conscious exam, and if we think that we need to do blood tests, urinalysis, or anything else for that matter, then obviously we see if our owner is amenable to it and try to do that if so. But if we want to look in detail, we're going to have the animal anaesthetised, and at that point we can do a full oral exam. We can also think about our x-rays and other tests like biopsies as well. So what can we glean conscious? Well, we start with the whole body and then we start working our way towards the head. So we get to our extraoral area. So really we're looking at a head and neck examination. And it's the usual thing where we're looking for lumps, bumps, anywhere that we might have draining tracts, things like that. Have we got symmetry or have we got asymmetry? Is that muscle wastage, etc.? What are the lymph nodes like? Thyroid, etc. Working ever closer towards the mouth, assuming of course that you've got a patient that allows you to do this safely. And eventually then we get to our intraoral examination, again at this point conscious, and we get a bit of a general idea of what's going on in this animal's mouth. With an amenable patient you may well be able to spot specifics. But it is very important to make our owners aware at this point that our conscious exam is compromised. Even with a very well behaved animal, you won't spot everything because so much of what goes on with teeth and in the mouth is below the gum line. So we just don't know. But we get a reasonable idea in a good patient. In a bad patient, in an aggressive animal, don't push your luck. It's really not worth it. And again, we would miss things anyway. So to some extent, you can kind of relax and hopefully get your owner to relax as well and say, well, even with patients where they're very amenable, we still don't see everything, and really we still need an exam under anaesthetic if we're going to be fully thorough. So it's not the end of the world by any means. We really need them asleep to have a good old look. But if you do spot something, so this could be a high index of suspicion, or of course it could be something specific. You spot a broken tooth, periodontitis, whatever it might be. But that one or however many lesions you've spotted is the ticket for this animal to get anaesthetised, to look at those, and at the same time therefore to look at the rest of the mouth and hopefully pick up all the pathology that we would otherwise miss in that mouth. In a well-behaved animal, the other thing that's good to check is the occlusion. You can see here we've got a fully closed mouth. Do that nice and gently so the tongue doesn't get crushed. And have a look at how these teeth meet together. What is the relationship of the jaws and the teeth within them? That's our occlusion. And we are not looking for Hollywood smiles particularly. Of course, there's many breeds where this sort of wild dog kind of occlusion is definitely not going to be found. So our brachycephalics, etc. But whatever their breed, their facial shape, what we do want to do is check that there's no trauma or impending trauma, either tooth on tooth or tooth on soft tissue. So try and check that. Again, aggressive animal, we'll have to wait till it's asleep. So we get our animal anaesthetised, and then we can start having a look. Now you'll notice I say anaesthetised, not sedated, because we're going to throw a lot of fluid around. We need to protect our airway, and also if we're going to do any treatment in terms of taking teeth out, for example, then again we're going to need an anaesthetic there. They can still buy you sedated. So that's what's required. Where we have an animal that we couldn't assess properly conscious, then we need to do this, and probably our first chance to do so is at induction. And once you're happy that you can have a quick look, then do so. And this might also be your opportunity to look at occlusion. So again, if you couldn't do that with the conscious, then tuck the tongue right back into the oropharynx. Quick look with mouth fully closed, left and right, rostral, then quickly tongue back, tube in. As you're placing that tube, remember to look at what it's going past, so the tongue, the tonsils, arytenoids, epiglottis, etc. And then once we've got this animal intubated and being stabilized, then you can have a little run round the mouth with some chlorhexidine solution, typically 0.12%, and generally it comes in a ready-made version for animals at that strength. So I dribble that round all the soft tissues and also the teeth, so I'm getting a general oral view, but importantly I'm doing my soft tissue check, and it's really, really crucial that you do that. We do it in people, and that's to assess various things, but the bottom line is a cancer check. So we're having a good look, and certainly I've had animals where I've picked up tumours, and the reason for them being dysphasic, etc. When people have been in, done dentistry before and not understood because the teeth didn't seem that bad, can't understand it, or maybe it's because there's a root or something, and actually it's because there's a tumour. And it's down to looking at soft tissues. It sounds very simple, it is, but it's vital that you do it, otherwise you're going to miss things. So underneath of lips, inside cheeks, palate, tongue, and importantly the undersurface, the ventral surface of the tongue, and the floor of the mouth. You may find that you can't see the teeth because there's so much calculus. If that's the case, you need to debulk, but this can just be with your fingers. You could use a hand scaler. We're not talking about a proper scaling, not ultrasonics or anything like that. It's just to gently remove it so that you can see the teeth and get the probe in. If you start scaling, everything will bleed and it will throw all of your gingivitis scores out of the window. So do so that you can do what you're doing, but don't go mad with it. They don't need to be perfect at that point. That then allows us to do our detailed examination, which of course is going to be our probing and charting. And once we've got our probe and chart, we then think about our radiography, and once we've got that, we also think about biopsies as well. So there's a number of different things, but the first thing, of course, to think about is probe and chart. So the equipment we need for our probing and charting is simple and cheap. It's our periodontal probe, an Explorer probe, and of course the chart itself. So perio probes, there's lots of different types, but this is a sort of a classic and very useful. It's the Williams 14, and the other type that I'd recommend, but really only for dogs, it's rather too big for cats, is a UNC probe. And what we need is a nice rounded atraumatic tip, otherwise it's going to damage the periodontal tissues, and also as many lines as we can, in that it's easier to record our depth measurements more accurately if these lines are quite close together. So here we've got a line at 1 millimeter, 2, then 3. We've got a gap of 2 millimeters, a central line at 5, another gap of 2, that's 7, 8, 9, 10. Whereas, of course, the UNC 15 probe, as you might imagine, has got a 15 millimeter capabilities. So, as I said, that's good in dogs, but not so much in cats. We insert gently into the sulcus. I usually go for the most mesial aspect. I also usually have my animal in lateral recumbency, but you can do dorsal recumbency as well. There's pros and cons to whatever you do. Gently inserted into the sulcus and then walked around the circumference, and you're seeing if it drops into anything, pockets, etc., that kind of thing. So you can get a lot of information, and that's going to be applied to every single tooth, and we're going to do it in sequence. So again, you start at your most central incisor and work your way right along that quadrant, and you don't miss any teeth out. The Explorer is rather different in that it's got a sharp tip, so a needle point, and we're going to use it only where absolutely necessary. So it's very useful if we think that there is, for example, a hairline crack, or maybe a bit of caries, decay, possibly a resorptive lesion, and it's quite subtle and we want to check that. We can use the Explorer probe, and that little metal point should catch if there are any disparities in our enamel. Because of course, enamel being like glass, generally speaking, it should just glide across the surface smoothly. So it's helpful to add to your visual examination. You get sort of a tactile feel as well. But the downside is that, of course, it also scratches enamel, which is why we don't want to use it where we don't need. and then we place it onto our chart, our map of the mouth, and it just is a really succinct way of getting a lot of information down as quickly as you can. And that's great in terms of forming a record that we can refer back to, but also for colleagues and, if necessary, medico-legal purposes as well. I've put here it's all opportunities because there's lots of times when we're not thinking about teeth, but we could do a chart, or not necessarily ourselves, perhaps our nurses or other assistant. So for example, if you're neutering an animal or doing any other non-emergency operation where the anaesthetic is not causing an issue for our nurses, then for example, if they're doing an anaesthetic check every 5 minutes, then there's a couple of minutes in between checks where they could just chart 1 or 2 teeth while you're perhaps doing another operation on this animal. So that's a way to get your nurses involved, and also to catch a lot of pathology that otherwise would just go under the radar. So whenever you've got chance, it's a really good thing to do. Use your work experience people, your nurses, etc., and try and get them involved with that. What do we put on? Well, everything that's abnormal. So you'll see here, I'm not putting plaque, I'm not putting calculus, I'm putting all the pathologies, and also what teeth we're going to extract, and of course when we've done it as well. The reason I say that is because plaque we're going to remove, calculus we're going to remove, and so other than doing a sort of a general comment about its presence, it's pretty much a waste of time putting any detail into it. So I'll just ignore that part of any chart if they're there and go straight for our pathology. And usually this will be relatively easy to do because there'll be a little abbreviation table for you, so you'll be able to see what the writing would be, the little code, an abbreviation for a resorptive lesion or tooth resorption or caries or whatever it might be. For missing teeth, we usually circle a number. For extracting teeth, it's usually a cross through the tooth's number, so we can then denote what we've extracted. But do be aware that you want to be quite clear whether you've extracted something fully or whether there are any roots left behind, or indeed if you're not too sure. It's far better to be open and transparent about this rather than make it look like you've taken everything out and write that in the notes when actually that might not be the case. Those are the cases that tend to get people in trouble, and it's where it says one thing but that's not actually the case. So try and be as accurate as you can about that. And again, with people, we do the same thing. You've either removed it in toto, or part of a tooth root, or more than one have been left behind, or you're suspicious that. But of course, if you're suspicious, then really we'd want an x-ray, but we'll come on to that. So periodontal disease, we will look at in more detail, but in terms of our charting, then we're looking at gingivitis as having a score, and also our periodontitis scores. So we'll look at each in order. So gingivitis, it's basically down to the tendency to bleed in terms of how we score. Again, it's by just gently going around that perio probe. Push too hard, it will both make everything bleed and also damage tissue, so we don't want to do that. We're looking at the cardinal signs of inflammation. So whether our gingiva is showing any signs of erythema, edema, and also the readiness to bleed. And here you'll see that a little bit of blood is following that probe around, and that was a very small amount of delayed bleeding, so it would automatically make it a G2, which is what we've got on the chart for a number of the teeth in this cat. But you'll see here is G0, in which case we don't write anything. That's clinical health. So for any of these scores, if the answer is 0 in terms of the score, that means health. We don't write it. We don't waste our pen. If we don't see anything written next to the tooth, that's what we're assuming. We've got the health there. So some examples here: nice knife edge of slope of our gingiva onto the tooth. It's a nice baby pink colour, and we certainly don't get any bleeding. So that would be a G0. Clinical health, we're not writing anything. Then gradually we start to get a little bit of inflammation, and we get with that a little erythema, sometimes a little edema. But if you run the probe around and we get no bleeding, that means it's a G1. Progressing from that, again you can see we've got a small amount of erythema, possibly a little edema, it varies again a little bit, but the crucial element here is that gentle probing gave our delayed bleeding. So that's a G2. Whereas if, as soon as we touch the gingiva with our probe, we get bleeding, kind of irrespective of how good, bad, or indifferent it looked before. I mean, of course, we're going to have a level of erythema and probably a level of edema, but sometimes it doesn't look that different to, for example, your G2, but it's the amount of bleeding. So almost a spontaneous bleeding and a bit more volume, that's our highest score, and it's a G3. And then, of course, when we move on from gingivitis to periodontitis, we're getting attachment loss, and we're starting to probe and measure, detect periodontal pockets, recession of the gingiva, and therefore exposure of the roots, furcational bone loss, and so involvement of the furcation, which is the gap between the roots of a multi-rooted tooth, and then also eventually, of course, lose enough attachment and you end up with mobility. So our pocket is measured in millimeters, and our recession, and therefore the amount of root exposure, is also measured in millimeters. So the pocket, we're measuring from the base of the pocket to where the gingival margin is. So maybe our base is somewhere in here, and we're measuring to this line. Okay. Whereas with our gingival recession, we can see where our new receded gum line is. It's here, and we measure from there to where our cemento enamel junction is, the CJ, and we get a millimeter recording between the two. Now, of course, this tooth might also have a pocket, so we might also go, well, we've got 5 millimeters of recession, and perhaps we've got, maybe a 3 millimeters of pocket formation as well. You can get them combined, and what you'll also see here is a multi-rooted tooth. It's a premolar, and we're getting furcational bone loss as well. With everything else, we've looked at millimeters, but as soon as we get onto our furcational bone loss, we're grading again. And you can see how we've used the probe to just see if it will go underneath the tooth. Very important that you do it from all sides. Here it's got right the way through, so it's no matter whether we started on the buccal aspect or the palatal, it would look the same. But of course, sometimes it's only from palatal, sometimes only from buccal, etc. So in terms of grading furcational bone loss, then again, F0, normal, we don't write it, full of bone. F1, well, we're starting to get our probe disappear underneath the tooth between the roots, but the probe has just gone in less than a third of the tooth's thickness. F2, and we're more than a third of the way under this tooth now, but we've not popped out the other side. Whereas with an F3, yes, it's 100%, so the probe will go from one side to the other because the bone in that area has gone. Bear in mind, however, that the gingival margin might not have altered much. So sometimes, although the probe would pass from either side, the gingiva kind of masks that, and that's what you're looking to kind of investigate around, is the bone loss that we're looking at. Gingival margin, as I say, might still be at the same height, so don't be fooled by that. The mobility, M0, normal, tiny little bit of give, about 0.2 millimeters, because of our periodontal ligament fibers, and particularly so for central lower incisors because we've got cartilaginous area there in our dogs and cats. But M1 typically on teeth where we're getting a movement from side to side of up to a millimeter, that will be an M1. M2, a bit more movement now, we're on a millimeter or more. And if we've got a vertical as well as horizontal component to the movement, then we're now on an M3 mobility, so blowing about in the breeze really. Of course, just be aware that multi-rooted teeth have this mechanical attachment, even though the periodontal tissues have really been destroyed to a large extent. The fact that for example, a 3-rooted tooth kind of holds them more steady, so we've just got to be a bit harsh with our marking for them. So we get all of this information onto our chart, and that tells us a lot, but we've still got a lot of information we need, and this is where your x-rays come in. the vast majority of a tooth is actually root. So 60–70% of your tooth is actually root. And it makes sense because the animal needs the teeth to stay in place, so they need really good anchorage. So we've got these big roots, several roots, divergent roots, etc. So to view those, then we need our other imaging, which typically would be the x-rays, of course. And without it, of course, we're guessing. So, we end up with difficulty with extractions often because we didn't realise there was an ankylosed root or there was a crack in the root and things like that. And also, we can't really get a diagnosis, and therefore we can't properly treatment plan. So, radiography is really fundamental to dentistry. And if you don't have it, then you have to do your best. But you can't do the same job. Unfortunately, you've just got to try your best. Important also for monitoring, and once we get to advanced techniques, it's absolutely imperative that you can do really good dental x-rays. When do we use them? Again, pretty much all the time, any pathology except where it only involves soft tissue. And you'll see also that I've put there before and after extraction. And that way you know what you're up against, you've got a diagnosis, and you can plan your extractions. And afterwards you can see, have I got everything out? Have I left something behind? And of course you can prove it to yourself, but you can show your clients, colleagues, and also if you needed to for a medico-legal purpose. And obviously a skull radiograph, well, better than nothing, but hardly the same as our dental radiograph. And that's because of all the superimposition that we get with a skull, unfortunately. Whereas the dental radiography eliminates that as much as possible. And we get a nice high resolution view as well. If we have something that you think might be sinister, then it's a very good idea to both get a radiograph and take a biopsy. So anything suspicious, better checked than left unchecked. And you can see here from the radiograph of the cat, there's something very sinister going on. We've got this loss of bone there, so an aggressive tumour. But actually in this case, the vet that saw the cat thought that they had, and the tooth that's now gone, or one of the teeth that's now gone, was a canine, had a mobile canine. As you can see, it's now gone. They removed it because they just thought it had periodontitis. As soon as you do an x-ray, that tooth was wobbly, not because of periodontitis, but because it sat within a neoplastic mass. So again, prognosis really changes, and obviously so does unfortunately the fate of the cat. But again, a radiograph makes it obvious, whereas actually clinically you wouldn't have thought there was that much going on with a cat. And when you do take your biopsies, make sure that they are a decent size. We usually use a wedge. You can use a punch as well, but a wedge is a good thing to do on the edge of the lesion, bordering normal tissue, but of course without altering margins. And if your radiograph shows that bone is involved, then ideally we would have a sample that incorporates bone as well. So it's important that good biopsies are done, and if you're not too sure, then again get some assistance with it. But they can make a real difference in terms of both prognosis and diagnosis, and therefore what treatment is done. And if you get an answer back that you think just doesn't match with my clinical impression here, then never be afraid to pick up the phone the lab, have a chat with them. They'll often do another look. You can get slides made up and get second opinions, all sorts of things like that. And of course, you do need to be careful that you can tally back which mass was from there. So the way I do is, if I'm taking several samples, I'll use different coloured needles. I'll have one sample, no needle, and that's from tooth, adjacent to tooth X, another sample with a blue needle through, then a green needle through, then an orange needle through, and it's all labelled on the chart. And then I also send a sample of that chart, photocopy, off to my histopathologist. The other thing is that, of course, if you've taken a sample from a very inflamed area, then actually that makes it hard for our histopathologist, because those cells are hard to interpret. So try and avoid that too. So in summary, our probing and charting is going to look at 30 to 40% of the tooth, and it really is your first and essential part of diagnosis and really assessing this mouth properly. But the rest, because it's below the gum line by definition, then we're going to need to start imaging. Once you've got all your information, make sure that they are archived properly so that you've got them to back you up, be that for planning, monitoring, or medico-legal purposes. And also, of course, you might have colleagues that you're discussing a case with, or it may be that you're looking at referring this animal, and all of this information is valuable stuff. Okay, so just make a note of any questions you might have, and then we can go through those when we have the practical sessions. So, periodontology, and we're looking at this particular issue because it's such a massive problem for our patients. Not only that, but it's completely preventable. So the more you understand about this, the better. The periodontal disease that we see will be on a daily basis, and it is the most common problem and disease there is, and that's not just of the mouth, that's of everywhere else, and the same is true for people. So you can see how big an issue it is, and if we can do something to get in there quick and prevent it, then so much the better. But there's a lot of things that people often get a bit confused about, so hopefully we can iron that out for you. So the periodontium, as you will probably know, is consisting of 4 different tissues: the gingiva, the periodontal ligament fibers, the alveolar or socket bone, and also the cementum, that outer coating to our root surface. And combined together, these are what supports our tooth and hold it within the mouth, and create this seal preventing the ingress of bacteria from the mouth and into the blood vessels and tissues of the inner animal. So great, it does a pretty good job, and it's as good as the body can manage. And it is a bit of an odd situation where we've got these extremely dense structures sort of perforating out through the epithelium. So, although it does a good job, it's not ideal, and one of the not so ideal things about it is that regeneration is something it's not great at, so rather limited. So once we've got damage to periodontal tissues, unfortunately, it tends to be there to stay unless we can do something fairly heroic, and often that's not the best idea if we've got plaque around, because that's what's going to make everything fall to bits. So the first disease we want to look at is gingivitis, and it's caused by the plaque bacteria that are sitting on the tooth and adjacent to the gingiva, within the sulcus and around the gingival margin area. So they are able to attach to the tooth. Although enamel is quite difficult to attach to, then certain species of bacterium are reasonably readily able to do so. They come in and can attach to the clean surface of the tooth, and then once they're attached, unfortunately, other bacteria can then attach to them, and so it starts to build. Now, the problem we've got with teeth, which is unlike elsewhere on our body, is that it's a non-shedding surface. We've said that enamel gets formed and it's a permanent layer unless, of course, it gets broken or worn away. And other than that, it's non-shedding. So bacteria, of course, are all over ourselves, our patients, but hairs are being shed, cells are being shed from the skin, from the lining of the mouth, the tongue, etc., but not true of enamel. So once we've got a number of bacteria attached to the enamel, then they are going to stay there unless we can dislodge them. And the sort of bacteria that first attach tend not to be too much of an issue, really, as far as the gingiva is concerned. However, give it time, and as the plaque starts to build, it also starts to have a bit of a shift in terms of the species. So while initially the dominance are gram-positive aerobes, then within 48 hours we're starting to shift towards a more anaerobic and gram-negative number of bacteria as well. And unfortunately, these are also the bacteria that start to cause us more issues as far as our gingival tissues, our periodontal tissues are concerned. They have the release of toxins and an antigenic effect. So we're starting to then get, of course, a host response. And as you might expect, that's inflammation. But these teeth are holding bacteria on them adjacent to tissues. So it's very difficult for the body to get at these bacteria because they're outside of the soft tissues. So undisturbed, we start to get this build-up, and also, as you can see from this scanning electron microscope view, we start to get a honeycomb formation, which is where we've got our calculus, which is our plaque becoming mineralized. And here again you can see that we've got these weird fronds forming. And these aren't individual bacteria, they're of course bacteria that are attached to others, attached to others, attached to others. And you might think that plaque is just this sort of amorphous, fairly translucent gel, but it's not. It's actually highly organized and very, very well attached to the teeth. So we have some bacteria using certain substrates, producing waste products, which are the substrates for another bacteria. So it goes on, they're communicating, etc. So we have a biofilm, a highly organized, well-attached biofilm. And that is very, very difficult to shift, as is the nature of, unfortunately, biofilms. So our host mounts its response, and that inflammation is what we see, of course, as gingivitis. So by definition, gingivitis is inflammation of the gum, the gingiva. And we know that we can identify it and score it using our perio probe, and also that gingivitis is only affecting the gingiva. So at this point, our other attachment tissues are okay. However, unfortunately, give it time and that's often not the case. So at this point, with only our gingiva involved, then if we remove the plaque, the biofilm, we break it up, disrupt it mechanically, which basically means using bristles, then we can reverse the gingivitis, and the gingival inflammation starts to reduce, so we can go down from, for example, a G2 to a G1 to G0, that kind of thing. But that means that we've got to be removing the biofilm on a daily basis. If we don't start removing the biofilm and brushing the teeth, and our frequency is not daily, then unfortunately the gingivitis can progress, and it's very likely in most cases that we'll get progression to periodontitis. And at this point we're involving more tissues, and the other slight issue is that it's irreversible. So again, plaque bacteria, that biofilm is the cause of it, but this time, as we say, 4 tissues, gingiva plus periodontal ligament fibers, cementum, and the alveolar bone are all involved. So we've got irreversible loss of attachment to the teeth, which is obviously a serious issue. So here we've got some sections of teeth, part longitudinal sections. This was courtesy of Dr. Gorrell from her book. And A is showing health, and we have our gingiva, alveolar bone, periodontal ligament fibers, cementum, cemento-enamel junction, enamel, obviously our dentine, and then we've got our sulcus, and we've got our epithelial attachment. All is normal. Head to B, and we're now starting to get a rather edematous or swollen looking gingival margin. So we've got gingivitis, and our sulcus is deepened, making it easier for more bacteria to hide away in that area, fairly anaerobic environments as well, and build. As we get to C, now we've got loss of attachment, and we're heading down. We've lost that area of epithelial attachment, so we've now got irreversible change. We've got periodontitis, loss of attachment. We've exposed this area of root into this pocket. So a narrow gap there. And you can see we've lost periodontal ligament fibres that were attached originally to our bone, which we've lost some of there, and the cementum. So we've got periodontitis, we've got a periodontal pocket. And where we go to D, then again the attachment of the periodontal ligaments fibres is similar to in C, and we've got similar amounts of root exposure, but it's a lot sort of a flatter area. So we've got our recession of gingiva, but you can see the gingiva can only recede, of course, because it's following the bone. But the useful element of that, we don't want it, of course, but the useful compared to C element of that is that at least we can tell that we've got a problem. You can also show your owner and they believe you because they can see it, and it's more open in terms of trying to get a bristle brush in there. So not ideal. We've got permanent loss of attachment, but C and deepening, ever deepening pockets is what we really, really want to avoid. So once we've got this damage, unfortunately we get a bit of a snowball effect because these nooks, crannies and rough surfaces like the cementum are far better at allowing the bacteria to attach and to gradually build up, to stagnate and cause more and more of an issue. So the net effect is often, sadly, that we end up having to take teeth out. So for periodontitis, we know that if we don't get gingivitis, we won't get periodontitis. Therefore, all our efforts have to be to try and minimise and prevent as much as we possibly can gingivitis. What we also know is that it's not just down to the plaque, although that's the big factor and the big factor that we can do something about, but there are other factors as well. So multifactorial, and some of these we need to try and find, but some of them will be, for example, genetic, etc., and there's not an awful lot we can do. But plaque removal, brushing has been shown to be the most effective, but it does need to be on a daily basis, and that frequency is key to success. And of course that's because of the way that the biofilm builds up and the time scale before we start to get our nasty bacteria back again. Now, the amount of calculus that's present is not necessarily a linear thing in terms of its relationship to the disease going on with the teeth and the periodontal tissues below. So often we do, of course, find that we've got all sorts of calculus build up, pretty nasty mouths, smelly, grotty looking, and underneath we have got a lot of disease, but not necessarily. So there isn't a linear equation between the amount of disease and the amount of calculus. So we need to make sure that we also look at soft tissues and that we're quite clear in our assessment of them, and make sure that we don't miss little subtle changes. For example, in our image here, then the teeth are relatively clean. They've not been cleaned, but you can see there's a bit of calculus here, but there. You can see that we've got gingivitis here, carnassial. So the teeth don't look too bad relative to these cases, but we've got this little draining tract here, this little gum boil. So that tooth has got an abscess sat on it. So obviously a painful problem, something that we need to do something about, but it doesn't look anything like, as a mouth, as problematic as these. So what often happens is these kind of cases go under the radar, whereas people spot these, they smell horrible, they look horrible, and they get booked in for treatment, which is a good thing. Obviously we want to do that, but don't be fooled. Just because a mouth doesn't look so horrible and smell quite so horrible doesn't mean to say that we haven't actually got quite a lot of pathology going on. So the sort of predisposing factors we might find, well, typically that will be systemic disease. So classics might be diabetes, but also renal compromise. Often we'll get ulcerative issues with that. Stress is a big one. So that can be stress, obviously, of an underlying disease, or it could be, for example, a new house and owner. It could be going into quarantine in kennels. It could be, a change of house, all sorts of things like that. And in people, that's really seen with all sorts of stressful life events. So, job loss, divorce, all these kind of things will often unfortunately take a toll on the body, and that includes the mouth, and so you'll suddenly find that periodontal health will start to take a nosedive. So we need to try and tease out whether there might be some factors like that, and of course that's going to depend on you doing that good, full, thorough examination, the whole of the body and also the history, and then adding into that any tests that you might think are relevant. We often get, with cats particularly, viral panels get done, which is good, but sometimes what gets missed out is just the plain old biochemistry and hematology, and again, it's an important thing. We've seen all sorts of things with blood tests that come back where, yep, there's something going on in the background that the mouth is an early indicator for. So we often do find that because it's got such a high cell turnover and a good blood supply, etc., then quite often it's one of the early places that we see signs of systemic disease. So again, don't forget about that. The other thing about periodontitis is that it is site specific, so you don't necessarily have the whole mouth affected, although that can be the case, and it might not be all the way around a particular tooth. So in this case, for example, we have a single tooth. Pointer won't move, unfortunately. So a single tooth where all three sides are perfect, but the fourth is not. And although it's only one of the four sides, unfortunately it spells the end because it's about a 10mm pocket, so the tooth has to be extracted in this case. But all the rest of the teeth, absolutely perfect. In the other photograph, then you'll see that we've got an area that does appear to be more inflamed. You can see the mucogingival line running along from premolar area to the molar, and in one area between two premolars we've got that area that's more erythematous, and the erythema seems to meet the mucogingival line, and the gingival margin sort of dips down. So that's a good indicator that we've probably got something going on there. We have got periodontitis at that point, and of course it's because we've got overcrowd, and therefore we're getting the plaque more easily retained in that position, and also it starts to stagnate. It's difficult to brush if anyone's brushing, and therefore we start to see an area that is predisposed to disease. Of course, the ginger might also respond in a slightly different way, and that can be hyperplastic, so we get overgrowth of the gum up the tooth, and as it does so, then we start to form what's called a false pocket. So if you were to measure the sulcus, and we've said that maybe on a canine tooth it might be up to about 5mm, then it might get higher and higher beyond that. We might get to 7, 8, 9, 10 or whatever millimeters without any loss of attachment, and just because the hyperplastic gingiva is growing up the tooth. So the false pocket that we get then, the problem is of course it does still trap plaque, and therefore we have got an area that is now predisposed to periodontitis because of that. So we like to trim these back and get back to a normal gingival margin. There's all sorts of complications that can come of periodontitis as well. Local extension and systemic extension. So if we'd have a look at local first of all, then one classic is contact or kissing ulcers affecting the mucosa that is lining the lips and the cheeks, but also it can affect the tongue as well. So in other words, where we've got our delicate mucosa sat on top of teeth or adjacent to teeth pretty much all day long, they're covered in millions of bacteria, so it's not an entire surprise really that we start to get those mucosal tissues be affected as well. And what you see with this is that the shape of the ulcer matches the shape of the tooth's crown, and of course potentially the calculus on it, as you see on this photograph. So that can be extremely painful, of course. They're really quite big ulcers a lot of the time, and we see some individuals more prone to it as well. So again, there can be stress factors, etc., but also genetic factors, and it can be to do with your collagen, it can be to do with your saliva makeup. There's all sorts of things that we may never find out, but again, it's something that needs investigating and treating aggressively ASAP because it's extremely painful. And wherever you've got these ulcerated tissues, inflamed tissues, particularly for a long period of time, we can get transformation and ultimately, in fact, tumour formation. So all of these cases, for welfare reasons, but also for the sort of long-term view, is that we want to try and get them treated as well as possible, as quickly as possible. So stomatitis is where the inflammation that often we would regard as gingivitis isn't restricted solely to that area. It's where we have, again, delicate, sensitive, lining mucosa of lips, cheeks, and tongue areas affected by inflammation. So classically, in a gingivostomatitis cat, for example, then this will be inflammation that goes beyond the mucogingival line. And of course, at that point, because it's sensitive tissue, it's extremely painful. Forsythus is inflammation of the pillars around the tonsils, so it's actually relatively unusual, but we do see it particularly in cats with gingivostomatitis, and usually not a great prognostic indicator. We can, of course, get abscesses as a result of periodontitis, and that's typically where we've got a deep pocket, sometimes in feccational areas as well, so our bacteria become trapped in a small sort of anaerobic area, and we get abscess formation. Then osteitis and osteomyelitis can be really, really nasty, aggressive disease. So instead of just relatively local areas of bone being infected, we start to get more and more of the bone suffering from inflammation and then infection from bacteria, and it's notoriously difficult then to treat these, very, very resistant to the effective use of antibiotics, unfortunately. So we often end up with extended antibiotic courses, but we also need to get back to healthy tissue. I've seen this in cats, I've seen it in dogs. I had a recent case, very, very nasty, virtually destroyed, well, yeah, pretty much destroyed all of one area of the mandible, and things like the neurovascular bundle had been reduced to just pus, literally just a green pus. So poor little dog, extremely painful, and we had to be really quite aggressive with that case. So again, if you see this, catch it quick and get help ASAP, because they can be really nasty and hard to treat. Systemic extension can occur as well, and particularly here what people worry about is with all that inflamed tissue, the very, very good blood supply that's there in the mouth anyway, added to which we now have the inflammation, and the billions of bacteria, it's very likely that we can get an easy, really, for bacteria to enter the bloodstream. So bacteria and their toxins can enter the capillaries in the mouth area and then, of course, head into the general circulation, and they tend to kind of seed out in fine capillary beds, particularly where we've already got compromised organs. The classic in people that gets worried about is bacterial endocarditis, particularly if you've had some form of disease of the heart before, or if you've had a sort of prosthetic heart valves, that kind of thing put in. But it can be other areas as well, as I said, particularly where they're compromised. So it's something to be a little aware of, and certainly where we've got immune suppression as well, it's something to be concerned about. Now, in truth, with a mouth that's so badly affected by periodontitis, now whenever this animal eats or plays with a toy with its mouth, basically uses its mouth at all, then you will get a bacteremia. And typically it's a transient thing, about 20 minutes, and the animal is well able to deal with it. Its immune system is robust enough to sort that out, and it's doing that several times a day, every day. But there are times when that risk is increased, and we know we're going to form bacteremia if we start playing in the mouth, scaling, polishing, and particularly extracting. So if we have a compromised individual, the question is whether we should be giving antibiotics to try and prevent further damage to these organs. So if we've got this sort of situation of a compromised patient, and they also have the periodontitis, and we're concerned about the bacteremia, then what we would typically consider, at least, is single dose injected antibiotic. So classically that would be amoxicillin, and you could give that IM just after induction, something like that, or it could be given subcuts. Again, timing wise, really what you're looking for is to have it on board when we think the bacteremia is going to be formed. So again, IM at induction tends to be fine. In people, you have it by mouth about half an hour before the procedure is due to start. Subcut we could do, at pre-med or whatever. Again, I say IM at induction mainly so that it's it tends to sting, so it's easier to give your dose that way, and the timing's about right. So it depends on the product you use, so have a little look at that and what timing is ideal. But that's the idea. Now, does it guarantee that you don't have a problem? Absolutely not. You can still get the compromise despite your antibiotics. However, I don't think it's necessarily a bad idea just to do where we have got the compromise. But in your average animal, maybe 8 years old, needs some dentistry doing, including some extractions, periodontitis, but generally a healthy animal, we typically wouldn't be using any antibiotics in those cases. The other thing that can be affected then is also pregnancy. So we know in people that women with very poor oral hygiene are more likely to have preterm babies and lower birth weight babies. So you can see how, again, everything links in. The mouth is part of the body as a whole, and this is just one example of that being the case. So, in summary then, periodontal diseases are caused by plaque, a biofilm that we need to break up to get rid of. If we don't get gingivitis, then we won't get periodontitis, but once we do have it, we get this catch-22, a self-perpetuating progression of disease, but that also it is multifactorial. Now, what I would say is we've said, generally speaking, I wouldn't use antibiotics except in specific cases, but it can be useful to use topical antibacterial agents. And chlorhexidine, some of these ready-made solutions at about 0.12%, they're ideal, and they are sometimes on your dental units in one of the bottles, so you can spray it on the animal's mouth from the air water syringe, or sometimes you'll get a bottle pre-made up that you can dribble around. So we've already talked about dribbling that around as we look at soft tissues, but that gives us a cleaner place for us to work, so it's kind of safer for us, safer for our pets as well. And once we've got rid of bulk calculus and things like that, and when we're starting to think about extractions, again, I would tend to just dribble around chlorhexidine in the same way that you would clip and prep a flank, for example, for surgery, and apply some form of antibacterial solution to the skin. We're doing the same for the mouth. We know about our probing and charting. It's not just about getting a cosmetically clean mouth at all. That's a nice addition, but not the aim. Now, when it comes to scaling, and therefore we're talking about removal of calculus, for debulking, I would use a hand scaler. I'm not a fan, I have to say, of calculus forceps. Yep, they remove calculus, but they also tend to remove crowns if you're not careful as well, so not ideal. The other thing is, very often the things that you have at the practice that are called the tartar crackers or whatever else they get called aren't at all. They're actually extraction forceps and not suitable for what they're being used for. Hand scaling, though, if we're going to start doing the detailed scaling, is really quite difficult to do well, and it takes a long time. So the best thing, of course, is ultrasonic, which I'm sure you've all got, and it's probably piezoelectric. So quick and easy, but we've just got to be a bit careful that we don't damage the teeth while scaling. If you're looking in the drawer at different instruments, then the way to recognise the scaler, which we should only ever use above the gum line, and as I say, it's useful for debulking so that you can get your probing and charting done, but it has a sharp point to it, and it's triangular in cross section. It's the photograph you see on the left. So the sharp tip or toe, triangular cross section of blade. You have to look quite carefully because it's only tiny, of course. And it's got two cutting edges. So that's why it's a bad idea to put it below a gum line. It's going to damage your soft tissues. Whereas a curette has a rounded tip or toe, and it's only got one blade, and in cross section it is half moon shape. So that's okay, done correctly, to bob into a pocket, for example, to clean it. But that's difficult. Again, I tend to use your ultrasonic, and the other thing about it is it's not quite as robust as a scaler. So curette's fine, you use it above and below, just be aware it's not quite as robust as the scaler. But generally I'd probably go for something like a sickle scaler that you only use for bulk calculus removal before you start your probe and chart, and your actual scaling is done with the ultrasonic. So the scaling is going to remove calculus and break up the biofilm. So that's fine. Both jobs are useful, but unfortunately it does scratch the tooth surface, and we have to minimize this, but it is going to do it, and therefore the tooth surface is left a little bit plaque retentive. It's a little bit rough. The best tooth is the tooth that's only ever seen bristles of a brush, of course. So we know that we're going to make a rough surface, so we only scale where we need to, i.e. where there actually is calculus, and we try and be careful while we do it. And one of those things, of course, is to make sure that we never use the end of the tip on the tooth, so we don't use it like a ballpoint pen. We use the side of the tip, so we need it to be near the tip to be efficient, but not the end of the tip. And also that we only have it on the teeth for a very, very brief moment and work up and down the rows of teeth, gradually getting each one of them cleaner and cleaner. Don't try and get one tooth clean and then move on to the next one and try and get that clean. So that way, unfortunately, by spending probably too much time on a tooth at any one time, you're in danger of heating the tooth up and thermally damaging your pulp. So instead we have plenty of water irrigating and cooling the tip. We have it on a low to medium power only, particularly in cats we'd have it on low, and we're only touching the side of the tip and doing the scaling for 1 to 2 seconds, I would say, at any time. There's not really an actual number that's safe or not safe, but I would err on the side of caution, get all of the elements correct, and only spend a couple of seconds on the tooth, and then go to the next one, the next one, the next one, then come back, and again and again. And you know, that way you get everything clean as fast as you can, but also in the safest possible way. So what does polishing achieve then? Well, it also breaks up a biofilm, that's fine, but it doesn't remove the calculus, so we tend to use it a bit less often, really. And when we talk about smoothing, well, it's not true to say that it smooths the enamel. It doesn't. Again, the best thing is bristle brush, and polishing with a Profu paste, it's like using a fine, hopefully it's like using fine, because we don't want to use a coarse paste or a medium paste, we want a fine paste, but like a fine sandpaper, so it will still roughen the surface. What it does, though, is when you scale, you'll leave microscopic bits of calculus behind. Now, the idea of the polishing is both to break up the biofilm and to just whisk off those final little bits of calculus. So that's well and good and useful if our owner is going to do toothbrushing. If, however, they are not, it is of no value. So you've just taken time and effort to do something that's basically briefly cosmetic and you know, relatively pointless, really. So if they're going to brush, then it gives them the smoothest surface so they can hit the ground running as well as possible. But if there's not going to be any brushing, all that will happen, of course, is all the plaque will come back and it will start to mineralise. You'll get calculus formation. That's rough as well, so more plaque can more easily attach, etc., etc. So in those instances, if you know you're not going to get compliance with brushing, there's no point wasting your time with using the polishing. If we are going to do it, then we want to use it on a nice low speed with a soft cup, so that as we very gently place the cup onto the tooth, as you can see here, the margin of it flares out. I want it to flare out into the sulcus, under the gum line, and clean in that very, very important area where the plaque tends to hide. So to do that, we turn the speed down by moving the rotating bezel on the motor, and get it as slow as we can, just a gentle purr on the motor, so that that cup keeps on rotating with that slight pressure to cause that flaring. So of course the softer the cup, the easier that happens and the less damage there is to the tooth. And again, what we don't want to do is heat our tooth up, so when we're polishing we do brief contact time with the tooth as well, and usually overlapping strokes, starting at the gingival margin and getting that flare, and then down to the crown, and then overlapping stroke again next door to that, and so it goes on. But no brushing going to happen, don't bother. Once you've done that, then make sure you flush the paste away, because it will inhibit healing if you're then going to start on your extractions. And what I'd then do is run the chlorhexidine round, as I said, before we start our extraction. So you can see that by cleaning the calculus off, then doing and removing the biofilm, this is a bit like our clip of an animal's flank, say for surgery of the soft tissue. And then by the time that we've dribbled our chlorhexidine solution around there, again it's like the clip and prep element, and we're ready for surgery. So the best thing, of course, from a periodontal disease point of view, is to remove the plaque. If we don't have the plaque biofilm, even if we are a person or an animal with a tendency towards periodontal disease, then we maximize our chances of having no or minimal disease. So what we do in practice is really the tip of the iceberg, and it's the day in, day out oral home care that is absolutely fundamental. In the same way that you might go to your dentist and occasionally have a scale plus or minus polish, but if you didn't brush your teeth in between, things would not look good, and that is what a lot of people do, unfortunately, and the net result is not very pleasant. So brushing is gold standard. We use a softer medium bristle brush, and it needs to be every day. So again, to break up the biofilm on a daily basis is what's required. And here you can see I'm doing a bit of a compare and contrast a toothbrush with a finger brush, and hopefully this helps illustrate why a finger brush is not good enough. We need to clean below the gum line, and you can see that the bristles will get to the area, but there's no chance the little rubber tags on a finger brush will. Also, your finger's quite big and bulky, and the smaller the bristle head, the better, because it can get in and around all the nooks and crannies and clean more effectively. Also, you might get your finger bitten. So effective brushing means using a bristle brush, and if we're going to do anything advanced, for example, there is guided tissue regeneration. We don't often do that, but there's also grafts, etc., that we can do for periodontal disease. That's fine, it can be done, but we've got to have an owner doing daily oral home care, because otherwise it won't work. It will all start to fall to bits because of the plaque presence. So home care is fundamental, and that means daily brushing. Here again, look at this finger brush, it's enormous, and look at the bristles on it. They're about the same size as those teeth. That was never going to clean below the gum line and into the sulcus. It wouldn't fit for a kickoff. Or here again, you can see how, this is virtually the same size as the cat's mouth or even head in this picture. So not going to be effective. And again, it will clean the tooth surface, but it cannot get below the gum line. So not useful, I'm afraid. So what we can do, of course, is to use things like our disclosing solution. It's really just a food dye that shows up where brushing is good or not good. And that's fine, but in reality, we can see evidence of that because we'll tend to find that we get a bit of staining, particularly from calculus in those areas, and of course our gingiva, our gums will start to react, and that's the area we will see gingivitis. So seeing where someone's managing or not managing is usually not too difficult. And what we need to do is make sure that they are motivated and maintain that. So using your nurses again is really useful. They can do a very good job at checking how owners are getting on, guiding them on technique, so little forward and back movements with the brush are what are required, exactly the same as for people. And also just doing the recalls, reminder cards, as you might do for boosters, things like that, is really effective so that you don't lose all your patients to the big wide yonder. You keep control and keep them monitored and see how they're getting on. And again, you can use that as an opportunity to see if you've got disease progressing and where they might be struggling, who's managing, who's not, any help that they might like and need, and step in and do treatments where necessary, for example extractions, and also to try and keep the motivation high. Other things, well, chlorhexidine solution is a good thing to use in many ways, but it's not the same as toothbrushing. It can't do the same thing, and it's got downsides to it as well. So if you couldn't do anything else, then there's that, but it's not really a replacement for toothbrushing unless absolutely necessary. Choose, there's all sorts of things that we could use here, but whatever you choose, one is to make sure it's safe, it's not going to damage teeth, so we tend to get broken teeth from bones and antler chews, unfortunately, and they're going to be chewing this for 5 minutes or more. So it's, again, the analogy is like us with chewing gum. If you only chewed it for 7 seconds and then swallowed it, probably wouldn't do an awful lot, whereas if you're getting a few minutes of chewing, then that saliva and its components is being useful in terms of flushing and its antibacterial effect, and we're getting an exercise for the teeth. So it depends on your dog. Again, a staffy is likely to race through a chew far faster than, for example, a little cavalier might do. So choose appropriately and safely. Things like rawhide, fine, but I would never leave a dog with any of these chews unattended, just in case they try and choke on them. Dental diets will always focus on plaque removal rather than anything else, so we're looking for something that's a big kibble, that's highly fibrous, that they've got to break into, so the teeth have to penetrate a long way into before it breaks, and then we are getting some sort of physical plaque removal. Again, will it go below the gum line? No, it won't, but if we're looking for belt and braces, then that can be a useful thing to do, particularly where we've got animals where they just won't let an owner do home care, or the owner can't do. There are cases, of course, arthritis, things like that. A lot of the time they just don't bother, and it's kind of getting it into their routine, getting it into a habit. And then there's all sorts of other things that are marketed out there that are, the next best thing, and you don't need to brush and so forth. But most of it, unfortunately, is not true. It's generally things that have come from the human side, haven't found a market with dentists, and so they turn their attention to vets instead. So, again, as with most things, sounds too good to be true. It probably is. Okay. So again, if you've got questions, happy to answer those. Often people have similar questions, so if you pool them and then we can have a look through, perhaps you could put them in on a form or something like that, and then we know, but you're fine to just ask them on the day. That's no problem. Okay, thank you.